Hello. Hi, guys. Can you hear me? Hey, Divya. Are you there?
There we go. Now we'll try and connect. I connect this to here, and then you can. There we go. Let's see if this works.
Hey, guys. Can you hear me?
Yes, it works.
I can hear you.
Oh, great. Hey, Brad. How you doing?
Good. How are
Hi,
you?
Prof.
Good. Hi, guys. Sorry, I'm driving currently, so I apologize. I won't be able to put me on screen. So maybe Brad, you can help us out on some of the things too. I'm sorry, guys. I'm on my way to a meeting. Brad, are you in Chicago already?
I am.
Okay, got it. Yeah, I'm on my way.
Yeah,
So
I'm in Chicago.
got it. Great. Hey, Divya. Hey, Lillian. How you guys doing?
Hello, we are fine, thank you. We had a presentation that Prof. Harris wanted us to present to you.
But he
Yeah.
needs to go.
And then you can give us feedback on what to do next because the patient is coming back soon. So we don't know if you have some time.
Yeah, please go ahead. I know Dr. Welling's also on the call, so he'll be able to see. Sorry, I know I'm driving and it's probably not the best thing for me, but I can listen and I'll do my best. Sorry.
Okay. So just a minute, we are just sharing the presentation, but the presentation is a 70-year-old man. And this man presented to us more than in 2015 for the first time. He came with a complaint of dizziness. His dizziness was typically multiple episodes, and the multiple episodes were associated with they were lasting for hours. It was like he could get like 3 episodes in a week. They were lasting for hours, and the patient was also getting a feeling of it was classic vertigo where he was saying the world is spinning, but he gets a disabling feeling where he felt like he would fall and veer to the left. So the other thing is that there was associated tinnitus that was high-pitched and continuous and unpulsatile. And the funny thing about the tinnitus is that it was not associated with the episodes of dizziness. It was constantly there on the left side. There was also associated oral fullness and a feeling of hearing loss. But the patient says that as far as he can remember, he never really he didn't lose consciousness, but the episodes would come and he would get so disabled that he would be transported back home from work. He has no neuralgia, no headaches, no auras, is a non-smoker, does not take allergy, does not take alcohol. He has no known allergies, and he works in a knitting factory where he works in the production unit but does not use any ear protection. So in terms of examination, on otoscopy on the right side, which is not the side of the complaints, he had a retracted tympanic membrane that was intact. On the left side, he had a normal exam. All the other exams were normal. Weber's was lateralizing to the right with a bilateral positive grinds. Head shake, head thrust, Dix-Hall, all of them were negative, including the cerebellar exam. As per the workups, his blood pressure was 116/70. His patient was a non-hypertensive. on HCTZ and antilipids. It's not clear whether he was on HCTZ or Lasix, but at some point his hypertension was treated with Lasix and then it was treated with HCTZ. The history is not very clear there. We also did a treponema pallidum test that was negative. And in terms of a tympanogram, his right side had a type C tympanogram, but the left side was normal. Bilaterally, he had the present stapedial reflexes. He also had a calorics that was done on his follow-up, and it showed 21% weakness on the left ear. Other than that, it was basically the weakness was not considered to be significant. On the left is his pure tone audiogram, and this is a 2015 audiogram. You can see that he has a mild hearing loss, which is pancochlear, you can say, with some sort of airborne gap in the low frequencies, which is bilateral, but it is worse on the right ear compared to the left ear. Also, that was an audiogram done in 2015. So his follow-up audiograms in 2019, because the symptoms have been progressive, the follow-up audiograms in 2019, he now develops a purely sensorineural hearing loss that is mild to sloping to moderate with a Boyler's notch at 4 kilohertz. And then in 2024, which is this year, the latest audiogram shows again a sloping sensorineural hearing loss, and that is more in the higher frequencies. It's a gradually sloping slope, and it is worse on the left ear compared to the right ear. In terms of speech, of significance is that his left ear has a speech discrimination score of 60%, but the right ear has a speech discrimination score of 90%. So initially, he had an impression of Meniere's disease, and he was cancelled on lifestyle modification. He was given betahistine without improvement. He was also given prochlorperazine with no improvement. And finally had some 5 months later, he got grommets inserted and was given intratympanic steroids. After that, his episodes of vertigo, which were as often as weekly, significantly reduced after the intratympanic steroids, and he could now get episodes in between the months. But they would be on and off episodes. They would still be the same characteristic, on and off, and with associated tinnitus and hearing loss that was persistent throughout. Of significance is that you have seen that in 2020, he had an ABR done that was also tallying or in keeping with the present audiograms. So currently, he still has, from 2015 till now, he still is complaining of dizziness. It's more of a feeling of lightheadedness, feeling like he's off balance. It is not aggravated by movement, does not have any relieving factors. Sometimes it can last minutes, sometimes it can last seconds. There are multiple episodes. He says it is not as bad as the initial attacks. There's no more vomiting. The duration is also shorter, but he's also presenting with hearing loss, autophony on and off, and the tinnitus is now bilateral. For the special investigations done, we also did a VNG that showed bilateral vestibular hypofunction, but this is non-confirmatory of Meniere's disease. I think it was a follow-up test, and the patient was still on vestibular suppressants. We did a HRCT of the temporal bone, which showed that the patient has a superior semicircular canal dehiscence. We're going to project the CT scan, and he has been booked for VEMPs, for vestibular,
I don't have the...
for VEMPs to be done. He has the flash here. So, okay. So Meniere's, our differentials are, we are torn between Meniere's disease, vestibular migraine, though the patient does not have any history of headaches. We have superior semicircular canal dehiscence that is confirmed confirmed on CT scan that we are trying to project right now, and a differential of possible vestibular migraine. So our main question here is what would be the way forward for this patient, because we are stuck. It is going to be very difficult for us to do the VEMS. We think the VEMS will be non-confirmatory because from 2015 to now, the patient has a persistent type C tympanogram on the right ear, which has not changed since then. And so with a type C tympanogram, we are not so sure how that is going to affect the VEM tests. And we also want to find out what else we can do for this patient to help them. He's currently booked to get hearing aids. So on these cuts, it is really difficult to appreciate the semicircular canal dehiscence. I think the axial scan is the one that shows us, but there's a very thin bone and the canal is actually narrowed serially on the left side. So maybe we can see it on this axial cuts.
Is it showing on your screen? I'm not seeing it right now.
Oh, can you see? You're not seeing the scan. Can you see the scan?
No.
Oh, sorry, let's screen. Let's
And
resume
Lillian,
the
I can't see him either, so I'm sorry, but I'm also on my phone driving, but
Oh, I saw it for 1 second. It flashed just before it went away.
Is it back?
No. But it was there. I saw it just briefly. It was black, and then I saw the scan that went away completely. Oh, there it is. I see it now.
Yeah, okay. So so these are his CT scans, and we're going to start from the top. We are mainly the most diagnostic side was the left side, where we can start seeing the canal there, and you can notice that there's a defect posteriorly on the left side, just here, which is more towards the posterior fossa than towards the dome of the canal. And at this point, it's covered by bone. On the contralateral side, which is the right side, though it was reported as a bilateral dehiscence, there's a significant amount of bone that is covering the canal. In terms of the reconstruction to the partial view, we've had difficulty having the reconstruction done, and we're not able to capture the right. But this is what we basically used to diagnose the canal dehiscence.
I'm sorry, Lillian, do you guys have coronal views at all? Are there any coronal cuts that you can show?
No, unfortunately, we are not able to NPR. And so we are only able to show these frozen images.
Okay, yeah, because usually on the thin cuts, we like to see at least 3 consecutive cuts in a row that would show dehiscence. There, it looks like he's really thin, but it doesn't look like it's frankly dehiscent there.
No, I agree. I think it's thin.
Do you
but
agree with
not
that, Brad? Yeah.
Yes, and
Yeah.
and if it doesn't look like it's completely dehiscent on a reconstruction, I doubt it's dehiscent, because the reconstruction would probably overestimate the dehiscence. So I think, even though it's thin, I think without true coronals, it's really hard to be sure. But I would say I don't believe. I see what you're saying on the posterior part of the canal. It comes close to the otic capsule, but I mean, the otic capsule looks like it might be dehiscent posteriorly. However, without coronals, it's just so hard to call that, I think. Yeah, I see that. I see where you're showing it, though. And it may be true. It may be there's a dehiscence there, but I'm uncomfortable saying that. So
Yeah. Yeah, I agree, Brad, for sure. Lillian, is there any way you guys can chat with radiology? Can they give you some reformats, or can they give you some cuts that are coronal based if you talk to them?
Yes, we are going to talk to them. We can ask them if they can give us some coronal cuts in the reformat, in the partial format.
Uh-huh. And that was
Yeah.
just so that was that the left ear we were looking at? I can't.
Yes, we were looking at the left
Okay.
ear.
Okay. And then do you have a similar frozen for the right ear? Like,
Yes,
do you
we
have a
do.
comparable cut for the right ear as well?
Yes, we do have, and projecting it right now.
Mhm.
This is the left ear. So this one, the other one, right ear. So the right ear has quite thick bone at the same.
Right.
Mhm.
Yeah. Yeah, I agree. It looks, yeah, so it's not convincing he's got a superior canal dehiscence. Now, the other issues are if you can scroll through the axials, is there any other third window phenomenon, say in the posterior canals? Can you see that if you go back to the axials and look closely at the posterior canal? Sometimes you can have a posterior canal fistula. So we want to look closely at the posterior canals bilaterally to make sure that there's not a fistula there that can be overlooked, or a dehiscence, I mean.
Lateral canal,
That one, yeah, that one looks pretty good there.
and the posterior canal looks like it's quite far from the edge of the bone.
Mhm.
Yeah,
agree.
I agree. What about the right side?
It's also covered well.
Yeah.
That looks fine too. Yeah. Yeah. So not convincing that he's got a, no, I'm sorry, Lillian, if you could tell me again on the audio, did he have reflexes? Did you guys do acoustic reflexes? Were those present or
Reflexes.
absent?
Yes, they were present on both sides. So when we look at his audiograms, the only thing that was suggestive of a semicircular canal is the dehiscence, is that on the initial presentation, there was an airborne gap, a low frequency airborne gap with the conductive hearing loss. There was an airborne gap in the low frequencies, but subsequently he develops a sensory neural hearing loss. And on the reflexes, he has a type C. He has a type C tympanogram on the right side, but bilaterally the reflexes are present.
Yeah. Yeah, I'm not convinced. I'm not convinced he's got canal dehiscence. It would be good to get the reformats before you make a final decision on that. On the first year we looked at, see if you
Yes.
can get the coronals. You might have a small dehiscence, but we can't tell just on the one cut. So I would see if you can get the reformats from radiology.
Or get the partial view, like you said,
Yeah.
you noted there. That would be helpful.
Yeah. And then Lillian, please remind me, does he have autophony and chronic imbalance with ear
So he
fullness that's kind of all the time? It's present there all the time?
Yes, he has chronic imbalance with ear fullness and autophony and tinnitus. The tinnitus is high-pitched and continuous, but of note is that he works in a knitting factory where noise can also, especially temporary threshold shifts, can give him the oral fullness, the tinnitus, and then the cumulative effect of a high-frequency sensory neural hearing loss. So it's also not very clear which of which, but the thing that throws his history off is the fact that he also has the dizziness, which has been there since 2015, was initially bad, treated as many years, improved, but it still persists.
But when you say dizziness, can you be more specific with a description? When you say dizziness, do you mean vertigo attacks, discrete attacks of vertigo?
So
Or did you,
initially,
because you had said some things about lightheadedness.
yes,
Um,
initially at presentation, he had discrete attacks of vertigo, which was
yeah.
classic with vomiting, and it was debilitating. It actually, he could not function, and it would last for approximately hours. But after the treatment with intratympanic steroids, he started getting feeling of lightheadedness or veering of some form of what he describes as he's still lightheaded, he's still unstable, or he feels like he's going to fall off. And this is aggravated by any form of movement. Sometimes lasts seconds, sometimes lasts minutes, and it can be as many as multiple episodes in a day, or sometimes he has good days where he doesn't have episodes. And this time there's no vomiting.
And
The other
but
symptoms, hearing, sorry.
go ahead. No, go ahead. Please go ahead.
The other symptoms, which are the hearing loss, the autophony, and tinnitus, are there and they are constant.
Yeah. Well, I mean, it's possible he could have the dehiscence in the ear, but I would look at those, rule that out first. You know, classic Meniere's disease, you know, they have to have vertigo, spontaneous attacks, 20 minutes to 12 hours, but they have to have concurrent ear symptoms, fullness, roaring tinnitus, fluctuating, usually low to mid frequency hearing loss. Now, the great mimicker of that is migraine. So he could have migraine in lieu of the Meniere's. It doesn't sound like classic Meniere's to me, especially if it's only lasting, you know, a few minutes. That would be not fitting with the clinical diagnosis of Meniere's disease. I have seen several patients that have concurrent SSCD and migraine. So there's a conundrum there of what are you managing first? Does he still have the ear tubes in?
No, the ear tube came out. He doesn't have the tube.
The tube's not in anymore. Yeah.
Yeah.
Okay. Okay. Yeah. See, 5 minutes to 72 hours. Now, Meniere's doesn't last more than 12 hours. So if something's going beyond 12 hours, that's not Meniere's disease. That could be migraine. So, and then he could have an element of SSCD layered upon that, but you'd have to look at that closer with the reformats. Yeah.
The only
So
caveat to that would be if initially the spells were fitting the true vertigo associated with Meniere's, but over time, if he got bilateral weakness, maybe he's complaining of dizziness that lasts for days. I agree that, you know, treating or considering, first of all, posterior fossa migraine and treating for posterior fossa migraine would be the most conservative thing to do. But you said he had bilateral vestibular weakness on his ENG as well. Is that true?
Yes, he did have bilateral weakness on EMG, but he was on vestibular suppressants when it was done. That is
Yeah.
something that was noted in his test.
It might be worth considering stopping the vestibular suppressants and repeating the VNG to see if that normalizes off of vestibular suppressants if you have that option. Because it does, I agree with Greg, right now it doesn't fit classic Meniere's, but it possibly could fit with kind of a burned out Meniere's picture if he had bilateral Meniere's and then it's kind of burned out, and so he has bilateral hypocaloric function. The other thing that seems to me not to fit quite as well with Meniere's disease is just his hearing loss pattern. The fact that he's kind of got a progressive high frequency loss is not that you couldn't have that with Meniere's, but typically, as Dr. Basura said, the low frequencies are more often involved early on. And his little air bone gap to me was kind of almost within test variability. it could have been from dehiscence, but it also could be that it was just a function of masking and one of the things I think would be useful when you see a type C tympanogram reported is to confirm that with pneumatic otoscopy. If you can get a good seal in the ear yourself and wiggle the eardrum to see if you agree that the tympanogram is flat. Sometimes it's tricky to get a good tympanogram, and so I don't know if you were able to do that, or if you thought when you looked at his tympanic membrane, it was definitely retracted. It sounds like, is that correct?
Yes, the tympanic membrane was retracted, and on otoscopy, which was to look for both the if it was going to induce vertigo or not, there was mobility of the eardrum, though a bit reduced bilaterally, and there was no vertigo on pressure.
Okay, good.
So the Honeypot sign was negative.
Okay, so so the retracted drum did move. It was just slightly retracted, but and that did not provoke vertigo. Is that correct?
Yes, it did move, but it did not provoke vertigo, and it didn't move as much as expected. It was a bit stiff.
Okay.
Yeah.
When I look at a retracted tympanic membrane, if it moves with negative pressure, I say, oh yes, that's correct. It's retracted. If it moves with both positive and negative pressure but stiff, then I think of something more like tympanosclerosis or middle ear fluid or something. Did it move only with negative pressure, or did it move with both?
Unfortunately, so I have to repeat that to confirm, because I'm not the one who did it.
Okay, okay.
It was reported on book on the
Reported them all. Okay, good. So this is a tough case, isn't it? These are always tough cases. But I think that it would be the most conservative thing would be start a vestibular migraine therapy regimen for a couple of months and see if that helps their symptoms overall. I don't know, Greg, where would you start?
Yeah, Brad, I agree. I think your point about the hypofunction is real. I mean, if he does have a true hypofunction, I think taking him off whatever he's on and then retesting that is really important, because if he does have a hypofunction and he's on a central vestibular suppressive medicine, he's never going to compensate for those losses. And so those folks, in my experience, they're chronically imbalanced. And so they won't complain of vertigo, but they'll just say, I'm off balance. I just feel off all the time because the brain has never learned to compensate for those peripheral weaknesses. So other things to ask would be about oscillopsia. Does he have like this term where the people will see the horizon sort of bouncing, or they'll feel particularly ataxic in the dark? So when you remove visual input, they may feel particularly off balance. But I think taking him off the central vestibular suppressives, seeing how he does, you might have to repeat the balance testing. And then if he does have some weakness that's disclosed, you may find that he did have, it's hard to tell. Then I think the symptoms will then come true once you get away from some of the central vestibular suppressives. And then you can start to kind of figure it out. The challenge with episodic disease is it can take months to actually drill down on the diagnosis. So Meniere's is tough to diagnose sometimes because it can be masqueraded by vestibular migraine. And because it's so episodic, you can go weeks or months without episodes, and then it comes back, and then you're trying to piece it together. So in the interim, it's tough for patients to have an understanding of what's going on. But I think Dr. Welling's point is really a good one, in that you may want to get them off the central vestibular. It's always good to be off central vestibular suppressives anyway, unless you only take those just for to stop or abort an acute attack. So if he's on that, I would stop that first, and then see how his symptoms sort of transpire, and then you can either retest him, or as Dr. Welling said, you could go down the migraine management. Does that make sense?
Yes, it does. And should we go ahead and do the VEM tests even when we have a type see
I would
tympanogram.
wait. I would wait a second. You might want to take them off the vestibular suppressives first, and then just let it ride for a week or two and see how his symptoms are. And I always tell patients to keep a quote unquote dizzy journal at home to be a good documentarian, because but they can't use the word dizzy in the journal. It's a dizzy journal, but they get more specific about symptoms. Because as you know, many of these things are pattern recognition, right? So things will declare, and they'll be many times patterned, and we can recognize those patterns clinically, and make a diagnosis based on how they present. So you may want to wait and get them off the suppressives first, for a little bit, and then see him back and see how he's doing. And then you could repeat the testing if you needed to. And then in the meantime, get the reformats from radiology. What do you think about that, Brad?
Yes, I agree completely. There's another issue that Dr. Becerra sort of mentioned, and I think it's one thing that I've bumped into from time to time, which is that patients that have true vertigo become so afraid of the attacks that they start taking vestibular suppressants all the time instead of just only when they're getting an attack. And that can lead to lots of problems, with them just being always drowsy or not quite on balance because of the vestibular suppressants. A lot of them have a side effect of imbalance or dizziness. And so I've had trouble sometimes when people have said, oh, I have to take this every day or I'm going to get an attack, when really it's so much more effective if they only use diazepam, Valium, or Antivert or something. If they don't use it all the time, there's certainly a tolerance effects that builds up with antihistamines, with Antivert, and there's certainly an addictive potential for the benzodiazepines. So I agree with Dr. Becerra. You really want to get them off of those, especially at this stage where he's kind of got chronic unbalance and it's not so much vertigo as he had initially. Get him off and just see if you can help with rehabilitation. With I realize sometimes that's difficult to convince patients to do that, but I really try hard to get them to do. What kind of vestibular suppressants does he use? Is it antihistamine or something more
Yes,
potent?
he's using an antihistamine.
Beta histine.
He
Okay.
previously had used histine, but did not give him any improvement. So he's now using chlorperazine.
Mm-hmm. Yeah, I would see if if off of those, if things and it's hard too, because if their symptoms start to get a little bit worse, then they think, oh, I'm getting worse, but they may be starting to compensate by coming off. So it's tricky. One other comment I would make, um, and I'm sure that you'd agree with this, especially given the way his audiometric pattern has progressed, that in an environment where there is some noise and he's not necessarily protected. I didn't quite understand exactly his work environment, but it sounded like maybe he has a noisy environment where he's not necessarily got hearing protection. That notch in the high frequencies is certainly suggestive of some noise-induced hearing loss earlier on. And I think that the term a temporary threshold shift is one that raises a little bit of a red flag in my mind, because in a single event where somebody has a certain level of hearing, goes into a loud environment, comes out, their hearing's worse, the next day it's improved. That's kind of the typical definition of a temporary threshold shift. However, we've learned that even in those circumstances where the pure tone audiogram returns to normal, there is damage done to the cochlear synapses that are going to the inner ear hair cells, and those are permanent, even though it's not measurable on a regular audiogram. You have to detect it other ways. And so I think the term temporary threshold shift is a bit of a misnomer, because it is true the threshold shifts temporarily, but the damage that's done to the cochlea is more of a permanent nature. And we think that patients get, lots of problems with hearing and background noise, and especially when they have other things going on like aging, it can really make it so it's more difficult for them to hear in a regular listening environment. So that's one little caveat about being careful about using the term temporary threshold shift. Some people may think, oh, that's good, it's come back to normal, but not necessarily so. And he may have several things going on if he's got Meniere's and some noise exposure, could be both.
Yeah, I think and I definitely agree with that. And Lillian too. The other thing is, most people with SSCD will have pulsatile tinnitus. I mean, I think his high pitched frequency tinnitus is probably from his, as Dr. Welling mentioned, his sensory neural loss, particularly noise induced hearing loss, is the number one cause of non-pulsatile subjective tinnitus. So I would guess it's probably from that, not from an SSCD, which would more give you a classic pulsatility than any other type. So that's another thing to consider. That's probably not, again, it may say that another piece of evidence to suggest he probably doesn't have SSCD, but not always. Yeah. One thing you could do, which, when they first described SSCD back in the late 90s at the Hopkins group, they used to think that it was pathic mnemonic by putting a tuning fork on the malleolus of the ankle. And if it radiated to the ear, people could hear it. They would say, oh, that's pathic mnemonic. I've had mixed sort of results with that, but one thing you could do is did you guys do a tuning fork on his ankle?
No, it has not yet been done. We
Okay.
plan to do
If you see him back, if you see him back, you could always you put a tuning fork on the ankle, see if he hears that in his ear. I mean, some people with SSCD will be like really, really prominent. They'll say, oh yeah, gosh, I can hear that. That's really loud in my ear. So it's kind of an interesting finding. So something to think about there. But again, I wouldn't use that as 100%, rule to say that they do or don't have SSCD. I don't think it's as pathic mnemonic as they used to say it was. I mean, at least in my experiences. So
the other comment about VEMPs I would mention is that I think that they're tricky to do consistently well. And if you do a lot of them and you're confident in the people who administer them, then I think they are helpful. But I also often hear from one of my colleagues, Steve Grosh, who I think is one of the early real pioneers in terms of VEMP testing. He kind of makes it sound like it's pretty hard to do them well, and and so I think the fact that you have had a hard time getting them doesn't really adversely affect this. It would be nice to have them and see, what they show, see if they support the dehiscent superior canal diagnosis. But more importantly, I think is what you have listed at the top is your partial view on a CT scan. And sometimes even reformatting is not adequate. They have to get the patient in the right position and do partial view in my mind. Now, I think this is an excellent case because it's so common. I mean, the things that you're talking about are things that people have a lot, and the early part of the disease process sounded initially, of course, like Meniere's to me, given the vertigo. Although I agree with Greg, 5 minutes is too short for Meniere's and 72 hours is too long. I usually say somewhere between 20 minutes and 24 hours. He says 20 minutes to 12 hours. And I guess I think that some people who have really severe vertigo will have kind of a post-vertigo symptoms of feeling just crummy and off balance and so forth for up to 24 hours. But true vertigo lasting more than that, if it goes 72 hours, I'm very suspicious that that's not Meniere's. So I like the idea of going down the road of treating the migraines, see how he does, and getting him off the central vestibular suppressants, maybe repeating the VEMP. And one of the one of the most common side effects of pulquerazine is dizziness. So some type of chronic imbalance could be related to his chronic if he's using it frequently, how often does he use the vestibular suppressants?
Well, in a week, he must take at least twice or thrice from what he says, because he always gets symptoms every week.
Uh-huh. But he
Yeah.
doesn't use it every day. He only uses it when he has symptoms.
Yes.
Oh, that's good. That's helpful
He was
because
using beta-histine is what he was using every day,
uh-huh.
but now he uses when he has the symptoms.
Okay. So you've already had that talk with him. That's good because I think a lot of people get afraid and take it every day when they shouldn't. Well, um, do you mind can you push his audiograms back up again one time? How is his speech discrimination?
Sorry, I didn't project, but the current speech discrimination is at 60% for the left ear and 90 for the right ear.
Really?
Yes.
Oh, that's surprising a little bit, isn't it? That there'd be such a difference in terms of the speech discrimination, given that the pure tones are not that different.
Yes. But with the
Yeah.
I'm sorry, you said but something, but what?
um
Yeah, it's not.
sorry, it is 80 and 70. 80 for the right, 70 for the left.
Oh, okay. Okay. That's not quite as worrisome then.
Yes, yeah, it's not so bad.
Yeah.
Sorry
Yeah.
about that.
Yeah. And you said you are trying to help him with some hearing aids, or is he complaining about his hearing loss as well?
Sorry, he's a candidate for hearing aids and he's been enrolled to have some hearing aids.
Yes. Yes. Okay.
Because
Well,
if you talk to him, his main complaint is that he really cannot, his hearing loss is getting worse and he's having a lot of trouble communicating. So his main complaint is the hearing loss, and then now the dizziness, the instability that comes from the dizziness.
does he have any family history of hearing loss? You might have mentioned that and I may have missed it at first.
But that we did not find out.
Yeah.
Yeah,
Um,
we can find
no,
that out.
yeah. Well, it's a very interesting case, and it touches on so many different areas that it makes it more difficult. It's not very clear. I don't think he has otosclerosis, as you mentioned. I mean, because he's got present stapedial reflexes, that doesn't seem to me like that would be likely the cause of that little early on conductive hearing loss. There are patients with otosclerosis who get what was termed otosclerotic inner ear syndrome, where they do have a conductive loss, but they also have dizziness with it. And that was explained on the idea that you have some otosclerosis going on that causes enzymatic disruption of the endolymph based on what's happening with the otosclerosis that causes people to have some chronic imbalance. I don't know. Do you make that diagnosis, Dr. Basura? Have you seen patients with florid otosclerosis that also had balance issues?
I have rarely have I seen it though, Brad. Yeah, I mean, the really bad cases that would be more in line with, cochlear otosclerosis, I've seen it, but just with your garden variety otosclerosis, I haven't seen it as often.
Mm-hmm.
Yeah.
I don't see it too often either, but in patients
Yeah,
who have
yeah.
that, where they may have florid cochlear otosclerosis or they have associated dizziness, we'll put them on bisphosphonates to try to help temporize their aggressiveness of the otosclerosis. The evidence for that being really effective is not huge, but I think it's something you do or something you can do to try to help mitigate it. I don't know. What do you think, Greg?
Yeah, it could be worth a try. Yeah. Like I said, I've only seen a handful of these folks in the past.
Mhm.
And some of those folks, what actually happened was their hearing loss was so bad that they actually were implant candidates, and I actually implanted several of those folks.
Mhm.
Which those are not easy implants because there's a
Yeah.
lot of intraluminal sclerotic findings, which makes it really challenging to get the implant in. But they did well afterward and didn't really have any issues with balance. But so it's fascinating. Yeah.
There's another instance that makes me smile a little bit. Think about very early in my practice, I had a patient referred to me who had one of the old single channel 3M cochlear implants in.
Oh, wow.
And he had been referred from a community physician who had put it in kind of in the infancy of cochlear implants. And he said, I think maybe he needs a multi-channel implant in the other ear because his hearing's so bad. Maybe you could consider that, or changing his single channel implant for multi-channel. And so I was impressed as I talked to this guy that he actually carried on a conversation really quite well. And I thought either he's a star user of his single channel, although I think I can't remember if his single channel was working at the time, but I thought his hearing is better than he appears. And
Yeah.
what happened was he had far advanced otosclerosis, so he had a severe mixed hearing loss. And with a hearing horn, I could yell in his ear, and he got all the words correct in the other ear. So he just did a stapedectomy on the other ear, and then put in, he could use a conventional hearing aid. And it's tricky when the hearing loss exceeds the ability of the audiometer to capture what's going on.
Yeah.
But
Yeah. That's interesting.
Mm.
Oh, wow. Yeah.
Well, listen, this has been a great case, Lily. I'm sorry.
No, go ahead, Brad.
I got to go pretty soon. Are you headed in here this morning? You coming to Chicago?
Yeah. I'll be here shortly. Yeah, I'm on my way.
Good.
I'm almost there. So
good. Do you think we could get a follow-up on this case in a month or so? Do you think that would be?
Yes, we are going to do a follow-up with the patient. We'll do the tests that you have outlined, and then we'll just give a report on the progress.
Yes, that would be very nice. It's a difficult case, but thank you for presenting it.
Yeah.
Thank you for
Lily,
the
just one last little things. Yeah, number one, I'm just going to echo what Dr. Welling said is, many of these balance patients, it's rare that they're like a unimodal kind of cause. Many times they're layered multifactorial etiologies. And so you have to kind of unpack a lot of these things, and it can take time to do that. So being a good diagnostician, but also having the patient being a good documentarian about their symptoms is really critical. The other thing too, that I'm asking more and more patients here, at least in the States, is sleep. I'm finding more and more sleep disturbances with patients that can lead to, all kinds of symptoms during the day. So I've gotten in a habit of really asking about sleep issues now more and more, and I'm diagnosing more and more sleep apneas, because that certainly can lead to, issues during the day with chronic imbalance, general fatigue, nausea, all kinds of different things. So that's just another thing in case you didn't have enough to think about, throw that on top as well.
Okay.
Yeah.
Yes, thank you so much.
Yeah, it's great. Yeah, keep us posted. Thanks,
Okay,
guys.
thank you.
Sorry.
Thank you all.
Yeah. Thanks, Brad. Thanks,
Bye-bye.
guys. Hey, Peter,
Thank you.
I think Peter's still on the call. He was on the call. Oh, he's off. Okay. He was on there for a minute, but well, thanks, guys. Have a great day. Good to talk to you.
Thank you. Great day too.
We'll see you next week. Bye-bye.
See you. So for you guys, for the residents, Tashnim had wanted you guys to know these things. Where is the PowerPoint? Hi, Peter.
Oh, you were on the call.
Yeah, he's connecting now.
Hello, Lillian.
Hello, where have you been? I hope you were on the call. We didn't see you.
Yes, my connection went off.
Oh, sorry. And you see, we have just finished. I was just
Oh,
emphasizing on the things that Prof. Harris wanted the residents to know.
Oh, okay.
Yeah,
Okay.
maybe we can listen. You can listen.
Well, so I'll get the recording. So.
Okay, no problem.
Okay. All right. Good to see you guys. Gift.
Good to see you too.
Yeah. Yeah. Hey, Divya.
Hello. Okay.
So he wanted you guys to know the diagnosis of superior semicircular canal, where you have pressure-induced vertigo, sound-induced, that is a vertigo and dizziness, the Hannibal's sign, that is dizziness on pressure. And then Tulio's phenomenon, which is dizziness by sound, and the presence of autophony. The patient says they can hear their own pulsations, their own voice, or their own footsteps, or even sometimes their eye movements. And then clinical examination may reveal eye movements induced by Valsalva maneuvers. So that's the oscillopsia. So any strain gives oscillopsia to the patient, and sometimes even the patient describes oscillopsia. And in the exam, how you want to ask the patient if they have oscillopsia, is you ask them how if they look at things on a shelf, and if they're able to, when they're having dizziness. So if they have a shelf at home or anything that is linear, if it moves up and down, then that is oscillopsia from the patient's description. Yeah, like supermarkets. Yeah, supermarket syndrome. Yeah, moving up and down, or if you're at home, yeah, or if you're at home, when you look at any of those movements up and down. Then the audiogram has an air gap, especially at the lower frequencies, and that is what makes it a differential diagnosis for autosclerosis. But remember, you differentiate when now you look at the tympanogram. In autosclerosis, the stapedial reflexes are absent. In the superior semicircular canal dehiscence, the reflexes are present. Then the CT scan, I think they have talked too much about this, the CT scan and the partial view and how you're supposed to identify the CVEMs. So there's CVEMs and there's OVEMs. She was very categorical about this too. She said, and this is what she wrote. She's going to teach you, but sorry, you can read at home. But basically, what I get is that the CVEM. Sorry. Yeah, but from me, I know the CVEMs and the OVEMs. So the CVEMs are cervical VEMs and the OVEMs are ocular VEMs. So the cervical VEMs, they test the circle, and the OVEMs test the utricle. So when you're talking about sensitivity, the sensitivity of the ocular vents is more. Sorry, for the cervical VEM, sorry, is more than the sensitivity of the ocular VEM. So this one is more than 90% when you're testing for superior semicircular canal dehiscence. This is 80% when you're testing. And how this works is through testing of the superior vestibular nerve, because they both innervate the circle and the canal. But then the ocular VEMs are very important. Then this is the one that is more. Wait, first, let us not confuse. Let us just. OVEM is more sensitive, yes, because it is utricular. It's more than 90% sensitive. CVEMs is a circle, so it's the opposite. So the OVEM and the CVEM. So the OVEM is utricle and it is sensitive. It has 90% sensitivity. And the CVEM is the cervical and it is 80% sensitive. Yes, I've even understood why. So when you're testing the circular, the circle test, the CVEM, when you're doing the CVEM, you test you put the ipsilateral sternocleidomastoid, but you're testing, comparing it to the other ear. And how it works is that the CVEMs are sensitive in identifying a third window lesion. So that is why you combine them, because so that is their importance, that they're able to identify when you compare one side and the other side. On the side that there will be a third window lesion, the pressure will be, or rather the whatever amplitude will be less, because the energy will disappear will dissipate through the third window lesion. So when you compare with the other side, you're able to get the differences. The other thing he talked about, she talked about is the ECOG in Meniere's. So I think that is the basic for the VEMS. So in the CVEM, in the OVEM, you're testing the utricle, you're testing mainly the nerve supply through the semicircular canals. That's how you test through. The other one, the CVEM, you're testing for the third window lesion. Then in the Meniere's, the definition, she wanted you to know the definition, the difference between definite Meniere's and probable Meniere's. I'm sure that you can read. And then also she wanted you to know the difference between a definite vestibular migraine and a probable vestibular migraine. And then management. Of course, it will go. About the ECOG. Yeah? So the ECOG is actually, from my reading, it is not really a very good, reliable test in differentiating or in identifying Meniere's disease. However, people still use it. And there is the intratympanic ECOG and extratympanic ECOG, where you can have the probe put inside on the promontory of the cochlea or the outside. Now, for the intratympanic, the threshold is usually, which one has less, which one has more. But the cutoff is 0.42 or on average 0.5, according to Tashnим. So a threshold that is less than 0.5. And what ECOG measures is that, and what this 0.5 is the ratio between the submitting potential and the action potential. So what is the action potential? The action potential is the threshold at the beginning of the cochlear nerve. That's why you talked about the APR. But what is summation potential? Summation potential is a potential that is measured by the movement of the basilar membrane towards the vestibular, the vestibular scala vestibuli. So when it moves, sound makes the basilar membrane move like this. So in Meniere's, remember there's a problem in the electrolytes because of the mix-up between the endolymphatic and the perilymph fluid. So this is usually reduced. So where you will find that the summation potential, or sometimes even because there's a mix-up, then they talk about rupture. There are so many theories, but the issue is that the potential in Meniere's disease is usually reduced, less than normal, because of that electrolyte imbalance, mainly the calcium and the potassium. So she wanted you to know that also. And yeah, there's no role of imaging in the Meniere's. I just made a table that is comparing the two, Meniere's and semicircular canal. So there's no role of imaging, but you can do an MRI especially because Meniere's can mimic multiple sclerosis, can mimic neuro lesions, like even a tumor in the brain, a posterior fossa tumor, even a vestibular schwannoma can present with symptoms that are similar to Meniere's, fluctuating hearing loss, dizziness, and all that. Then in superior semicircular canal dehiscence, the CT scan is a gold standard, but then you see that you can do an MRI, though it is neither here nor there. It's not really diagnostic. Another important differential, which is a differential for both of them, is autosyphilis. So tertiary syphilis, where patients will both present with similar symptoms. They will, and in both, they have the Hannibal sign positive. So if you do, for all of these patients, you have to do a syphilis test so that you can differentiate them. Our patient got a syphilis test and was negative. Yeah. No, that's what we were saying when he asked if we did, it was retracted, it was moving, but there was no vertigo induced. Yeah, but in Meniere's, when you do it, the vertigo is usually horizontal. Sometimes it can be torsional, but it is horizontal. For superior semicircular canal dehiscence, it induces oscillopsia, which is vertical fluttering movements of the eye. So that is the one major thing that you can use to differentiate also.
What do you use to
You know, calorics is a test of vestibular function. Both these diseases will give you a vestibular hypofunction. So calorics test is neither here nor there. Even VEMS, they're called VNG. VNG is also not neither here nor there because it will give you a hypofunction. The role of VNG is only in Meniere's disease. When you want to follow up, especially when you're doing ablative treatment, you want to follow up and see if there's any residual vestibular function, then you can do a VNG. But before, it is neither here nor there. It's not an issue for diagnosis.
I wanted to find out what do you use to elicit the Tullius? Do you use tuning forks?
Yes.
Okay,
You just use, if you use a tuning fork, a Weber's, actually on the Weber's, even some patients will even just tell you. But on the Weber's, because it is the bone conduction, the sound will be really high. Remember, they have supracretion here.
And then what's the pathophysiology? What's the why do they hear when you put the tuning fork on the ankle?
Supracretion here.
How is it transmitted by bones?
Yeah, the bone.
Yes. So the air. Yeah, but it is the third. That's a classic symptom of any third window lesion. So a differential for a positive Tullius phenomenon is a differential for it is if you have a patient who has a positive Tullius phenomenon and they have a discharging here, it could be a cholesteatoma with a canal fistula, because a canal fistula will also give you supracretional because of the third window lesion. So any third window lesion, that's a sign, positive sign. Yeah.
What are the types? Okay, I know the semicircular canal disease. Vestibular aqueduct.
Large vestibular.
Or cochlear aqueduct, so vestibular cochlear.
Any hole other than the oval and the round. Yeah.
Got that.
You can do them from top to bottom if you think like me.
From audiology, how do you differentiate on audiological examination between otosclerosis, which is a differential for all third window lesions, and say semicircular canal disease? How would you differentiate on pure tone, maybe on reflexes, and
some patients with the otosclerosis, this is a stapedial reflex, but on otoscopic, some patients with otosclerosis have the sign, the short sign.
Short sign. Short sign is when you look into the ear and then or pass through the tympanic membrane, you see
a pink flash on the
so that's like hypervascularity. Flamingo sign.
Yeah.
Hypervascularity of the promoter.
Yes, due to increase in the active phase only.
And then let's say you have done your CVEM or VEM. How would that help to differentiate otosclerosis and semicircular canal disease?
Otosclerosis is a medullary disease.
So I'm just saying.
But in cochlear otosclerosis is going to be different, because how you will differentiate is you will differentiate it on your CVEM. Remember, we said the CVEM is testing the circle, and what it does, it tests for a third window lesion. So a CVEM is sensitive for any third window lesion. Otosclerosis does not have third window. So it will be an increased threshold, but it will be depressed in a.
So, but you can use that to differentiate for the otosclerosis.
Yes.
But go for this circadian reflex.
Yeah, it's very good.
Yes, it would be normal, but remember, we talk about either they will be equal or it will be more than the, not even more than, or maybe it will be more than the opposite side. Because what we look for is we compare with the other side and then we report it as less than. It's a comparison test. It doesn't have like fixed. Yes. In any third window lesion, like it's less because the energy is immediate. Yes. Yes, normal or yeah, it's similar to the opposite side. It's best to report that it is similar to the contralateral hip. No, sorry. You see, yeah, it will be less because what we are talking about is we are measuring the sound is coming from here and it is dissipating going into the ear. So, and we're looking at the displacement of the muscle. The displacement of the muscle will be dependent on how much energy has been transferred. So if you have a third window lesion, it means that the seal to have the energy fully transferred is broken, so some energy is lost. So the test in a third window lesion is always depressed. Yeah. If you have cochlear autosclerosis, your problem is that you just have bone in the cochlea. So you have a sensory neural hearing loss, but there's no nothing, there's no hole on the bone to make you lose your energy. So it remains the same. That is for the ovum. The ovum now is the one that is looking at, it follows through the vestibular now, then it has to, because it's the eyes and then the superior semicircular. Yes, but now this is purely sebum. There are two different tests, but they, yes.
In the Congress, I went to help out set up the theme and the ovum. I never seen it, but it looked like it was very complicated for almost everyone. Yeah, but the audiologist, there was a guy from, I think, Egypt. He was the one who is like the guru in this thing. And it was very interesting to see how they do it. They put the probes on the stenoplate master, the ocular, but yeah, it's quite complicated.
It's interesting, even this Prof. Wellington has said that it is one of those tests that is equivocal. Like it is really